Is up, party people? Today we're going to be going over diabetes and how it relates to pathophysiology as well as pathohistology. So on the screen, I'm showing you a bunch of descriptors that you may get as answer choices for a given question. Let's say they give you an example of a child that has signs of diabetes. It's then up to you to be able to discern which one of these would fit. Now, right now may not make a lot of sense, but let's run through it. So option number one, amyloid deposition and reduction of cell mass. So this is something normally that you would see in type 2 diabetes, indicating the chronic nature of that disease. If someone has type 2 diabetes for many months or many years, and then you biopsy their pancreas, you would expect to see amyloid deposition. That's very characteristic of long-standing type 2. Amyloid stains apple green bifringence with Congo red. This is buzzword stuff you have to know. You have to memorize that. So when you see amyloid or apple green stain by refringence with Congo red, you have to be able to connect those dots. Next up, atrophy and fibrosis. I want you connecting this to long-term type 1 diabetes. If you were to biopsy a pancreas 20 years after the initiation of type 1 diabetes, then sure, you could find some atrophy and fibrosis. Next up, we have enlarged beta islet cells and nuclei. This reflects beta cell hyperplasia and hypertrophy. This is something you would see in acute type 2 diabetes due to insulin hypersecretion from insulin resistance. This is tricky because type 2 diabetes can sometimes present acutely, just like type 1. You might get a 50-year-old dude who's overweight with a 2-week history of intense thirst and weight loss. You might think, wait, weight loss? Yeah, that's how acute type 2 can present. Weight loss and thirst, especially in older, overweight people. And just as a fun fact, don't rule out type 2 diabetes in younger patients. I've seen a 17-year-old who's overweight and has type 2. So don't assume just because they're young that it's type 1. So again, enlarged beta cells equals acute type 2, hypersecretion stage. Amyloid deposition equals chronic type 2, burned out beta cells. Okay, next is lymphocytic infiltration and cytonecrosis. This is what you see in acute type 1 diabetes. So there's a lot of mechanisms that can be cited for type 1 diabetes. But one of the proposed ones, a favorite one that they like to reference is Coxsackie-B. Coxsackie-B can cause dilated cardiomyopathy. However, it can also trigger type 1 diabetes via molecular mimicry. The immune system forms antibodies against 6-amino acid oligopeptide from Coxsackie-B. Then those antibodies cross-react with GAD65, that's glutamic acid decarboxylase 65, as well as zinc transporter 8. These are beta islet cell antigens. So anti-GAD65 and anti-zinc T80 antibodies are commonly seen in type 1 diabetes. You have to be able to recognize these. So you get a T cell mediated response in addition to antibodies again. Many mechanisms that can lead to type 1 diabetes. But lymphocytic infiltration with necrosis is the most reflective of acute type 1 diabetes. And finally, thickening of the basement membrane. This is the first histologic change seen in the kidney, both in type 1 and type 2 diabetes. Another fun fact is if they were to ask you, what would be the first overall change in the kidney as a result of diabetes? The answer would be hyperfiltration. That would be an increase in the GFR. That's pathophysiology. However, a histological change would be basement membrane thickening, which disrupts the charge and size barrier leading to proteinuria and diabetic nephropathy. So to recap, key points are amyloid plus decreased cell mass equals chronic type 2. Enlarged beta cells equals acute type 2. Atrophy plus fibrosis, chronic type 1. Lymphocytes plus necrosis, acute type 1. Basement membrane thickening in the kidney, not the pancreas. Now, if I was to ask you, in ketoacidosis, specifically diabetic ketoacidosis, what you would see in the blood levels. Here's what you would see in relation to potassium, sodium, bicarb, pH, and CO2. Increased total serum potassium, decreased total body potassium. The increased serum potassium would be due to acidosis shifting potassium extracellularly. Decreased total body potassium due to urinary loss. And don't forget, normally insulin is what shifts and basically pushes and drives potassium into cells. Therefore, if you don't have insulin, such as in diabetes type 1, obviously you would have a high level in your serum and a decreased amount in your cells. You would have decreased serum sodium, decreased serum bicarb, decreased pH, despite decreased CO2, which would be due to the respiratory compensation, the blowing off of that CO2. All right, that's it. Go crush it.